This is a gentle introduction into 2022, just with a quick video that's been sped up a little bit, demonstrating the slight changes I've made to the way I do lens removal. I try and focus on cystotome and try and make the rexus as central and circular as possible, yet trying to make the size within the limits of the optics, which are normally about 5.5 to 6 millimeters. As you could see, I tend to mark the cornea even though I don't use even if I'm not using a toric lens, simply to go on axis and try and reduce the amount of induced astigmatism that I create. Here I just do gentle hydrodissection. I try and wait till a wave just passes the cannula, and then I press down on the proximal part of the lens, and then you see the wave come forward, and then you can just rotate a slight amount just to make sure that the lens is actually mobile. As you can see, I still use the mushroom and the chopper as well as a second instrument, but I use the mushroom to lift up the wound to insert the phaco probe. With the phacoemulsification, I try and make the grooves as straight and narrow as possible so I can make a clean break. I try and minimize any stress on the capsule, just try to put enough force on to break the lens into segments. And here I'm going deep enough just to be able to break the lens into segments. I'm trying to minimize the amount of energy I use, and I try and minimize the amount of manipulation within the eye. Now I'm gently taking away the segments, staying on the anterior capsule plane, trying to avoid bring anything into the anterior chamber, and trying to minimize the amount of debris that's released from the phacoemulsification process. Here I'm removing the last segment, and I do regularly use HPMC now to coat the cornea for any intraocular lens surgery. And now I'm getting the IA ready. I tend to use coaxial IA now, either silicone tip or its equivalent, as you can see here. And again, I try and stick to HPMC. I do a sweep and pull technique, increasing the vacuum as I'm pulling towards the middle of the eye. Very gentle, try and reduce any stress on the capsule itself, and try and remove the SLM in a clean way, and ending up with the sub-incisional plane, which is often the most challenging, but isn't too difficult now with this kind of curved tip. I also am a big fan of the polish mode, so I try and clean any residual cortical staining or opacification. And when I do the injection with the viscoelastic, I try and fill up the bag, especially when I'm using a capsular tension ring, which I'm not in this case. So now that I'm getting the lens ready, it's a single piece of lens, just gently inject it into the anterior chamber, try and get the haptic to line up underneath the capsule. And I'm very careful when I inject the lens now. I try not to inject it too quickly, just try and make it a nice, slow, controlled process, and watching how it behaves and how it unfolds. I try and avoid allowing the haptic to touch endothelium at the wound, so I do use the mushroom to gently insert the lens into the bag rather than trying this in one go. Now I'm doing IA on visco mode, and here I'm quite keen on removing all the viscoelastic, especially the stuff that's behind the lens, which can cause a myopic shift afterwards or a capsular distension. And here I'm trying to just gently manipulate the lens to try and remove the viscoelastic from behind, and ensuring that the lens maintains its central position. I do very gentle stromal hydration, and I try and get a feel for how the wound is. If it's obviously leaky, then I have a low threshold to put a varicose suture in place. Here I'm putting the cefuroxime and intracameral dexamethasone